I'll do the intro, guys, and then I'll be handing over to you.
Okay.
Okay, we're recording, Gabs. Okay, well, good morning, everyone, and thanks for joining us. Hopefully you can hear me. My microphone's not playing very well today, so my apologies. I'll try and speak up, and I don't want to get too close to the screen and scare everybody. But welcome today. We've got some very special speakers today from the Royal Bucks, and today's webinar is about spinal injuries. So we've got some real experts to help us. For those of you who don't know, I am Jill Fraser and I'm the Clinical Director of Maya. We run these webinars usually monthly, usually the first Tuesday of every month, with different subjects of interest that are relatable to all of us and all of our clients. And we predominantly provide these for our associates and our rehab assistants, just to give them something extra and a greater insight into the clients that we work with. But we found that it was so good that we wanted to share it. So we share this now with anybody that wants to join us. We're always looking for new speakers. We think it's a great platform to share this information and to let you know what's out there, what's available to all the clients we work with and how we can help them. As all of us are part of some sort of MDT, it's really useful for us to share this information. The training we offer is the non-mandatory training, and the webinars are, as I said, they're of special interest. We will do things like anxiety, depression, loss of limb, spinal injuries, as today, applying for benefits, the slightly less interesting things. And next month we have quite an interesting one on September the 6th. We've got sex therapy, which is something that often we don't talk about with our clients, the clinicians or the rehab assistants, case managers. We tend to leave it to other people, but having that knowledge is going to be really useful. So that's next month, just to let you know. So please sign on with that. Our speaker is somebody called Beaver Meadows, and I think it's going to be quite interesting. So many of us, I was just speaking to our guests just now, and many of us will have heard of the Royal Bucks, but there's so much more to what they do. And I know that our guest speakers, who are Shiva and Marcello, Shiva, you're an OT, is that right?
Yes, I'm an OT by.
And Marcello, you're physio.
Yeah.
By background.
Yes.
Okay. So they have got an awful lot to share with us. And I'm sure once they have provided us with that information, they will answer some questions at the end. Yeah, great. So sit back and enjoy this. It's really interesting. It's spinal injuries. And let's hear what they've got to say. So thank you. Over to you guys.
We'll just share our screen and start from there. Give it a second.
Good.
Good morning and welcome everyone to this session on spinal cord injury management and care. We are two very passionate professionals. We are here to share what we do in our day-to-day work hours, that is treating and seeing spinal cord injury patients. So we are here to share our thoughts on how the rehab process goes as an intensive package, and generally to give an overview of what is spinal cord injury, what are the functional levels of spinal cord injury, principles and of rehabilitation and management, patient pathway when they come to the Royal Buckinghamshire Hospital, the tools and technologies, which is the heart of our rehab model. And spinal cord injury, as you all would be aware, is a lifelong care and requires lifelong support. So I hope you would enjoy our webinar. We will take questions in the end. So now I'll introduce myself. I am Shiva. I am an occupational therapist by professional background, and I am heading the therapy services at Royal Buckinghamshire Hospital. So I've been in spinal cord injury for the last 20 years and totally passionate about it. I'm joined by my colleague, Marcelo, and I'll let him introduce himself and his accolades.
Perfect. Yeah, we've been working together for a while now. Let's not count how long. Yes, I've been working with spinal cords and all neurological injuries here at the Royal Bucks for the last 10 years or so. So working as a physio together, and well, we want to talk a little bit more on how we deal with spinal cord injuries, which is our bread and butter. Yeah. So spinal cord is a catastrophic injury, is a life-changing event. Yeah, that will have different results depending how the accident happened. Yeah. So nowadays we're talking there are about 50,000 people in the UK who suffer spinal cord injury. Yeah, it's about 2.5. I think the near numbers are talking about nearly 3,000 people every year in the UK with new spinal cord injuries. There's a little bit less now during the pandemic years, but on average, it's about 2.5 every year, which is quite a significant number. Yeah, these injuries, they could happen for a number of different reasons, but usually we separate them into traumatic and non-traumatic. Yeah, so traumatic, well, the next suggestion would be, if you had an accident, if you jump off a bridge and and then you fell, or a car, this sort of stuff. And then non-traumatic is when you have, either a tumor, or spinal stroke, degenerative diseases, infections, everything that comes from within. Yeah. On average, we're talking about 50 years old, and a third of these injuries, they are considered complete injuries, whereas the other 2/3, they are called incomplete injuries. Okay, so the spinal cord is this connection that we have between our power, the central power, the brain, is what connects the brain to the rest of our body, is what communicates. Yeah. So this would be like in your house, would be the power, the information that comes from the energy power will then divide. Some cables will go to your room, some cables will go to your bathroom, living room, etc. Yeah. So depending where an accident might happen, where an affection might happen, this will have different consequences. Yeah. Of course, the higher the injury, the more parts of your body and of your function will be affected. Yeah. So we separate into pretty much 4 bits, which is cervical, thoracic, lumbar, and sacral. And then depending where you hit, it will get different parts of your body. And from that, knowing the anatomy and the physiology, we can then come to some conclusions, depending where the accident is, depending where the injury is. We can have an idea of how this person might look like, what sort of condition we might expect based on their presentation, based on where the injury is. And then we can start wondering from average what type of assistance they should have. Yeah, will they be dependent on doing their DLs? Would they be independent? Would they need assistance? Would they be able to breathe on their own? How is bladder, bowel, etc.? This is all depends from where, and depending where we can come to conclusions then. Okay, there is a standardized assessment. It's called an ASIA or INSCI score. That's what they're pushing out first, to call it the INSCI score. But we call colloquially, we call the ASIA assessment. So this is when someone comes to us, or to anyone with a spinal cord injury, is the first assessment that we do, that tries to identify where is the cut, where is the injury. Yeah, not only where the injury and how that is presenting. Yeah, because you can have different levels of injuries and different types of compromise as well. Yeah. So when we're doing this assessment, this is standard. So if you do this assessment, here in the States, in Australia, it doesn't matter. It's going to be exactly the same. Yeah. And then it's going to give you, so when you see someone who comes with a spinal cord injury at level C5, for example, yeah. So we know that C5 is the last level where everything is normal. Sensation is normal, pinprick is normal, power is normal. Anything below that, there's some sort of impairment, okay? So this sort of impairment, we can classify as well using this tool. We can call complete. So complete is when there is absence of sensory or motor input below that level. Yeah, we call nature A complete. Yeah? So anything B, C, D, and E, they are called incomplete injuries. Yeah, and they range from being B, just if you go colloquially, so B is you have only sensation below the injury, but you don't have power. C, there is some power present, so there is some connection going on, but not much. D, there is definitely more gravitational. You can go against gravity in most muscles below the level of injury. And then E, power and sensation are absolutely normal. You had an injury, but there are no, we cannot see anything on this examination. Of course, examination is all about this, but this is the standard way. It's quite straightforward. It's something you can do on the bedside, especially if you're in an acute phase, where you're going to do this day 1, day 3, first week, second week, and then you start spreading out. From that as well, it gives us, yes, it gives us a diagnosis, it gives us a level, it gives us if it is complete, if it is incomplete, but we can also draw some conclusions on some types of syndromes that we can have. For example, does the person present as a central cord syndrome, as a Brown sequard, as a cord equina? So these are different presentations that we're going to act slightly different depending on how this presentation is. A central cord is usually the person that can walk, will manage to walk, to stand, to have movement of the legs, but will struggle to move arms, for example. Yeah. The Brown sequard is what we call a hemisection of the spine. And then they have different impairments on both sides. So one side they can feel pain and sensation, but then on the other side they don't feel temperature and vibration. It's varied. It changes from one side to the other. Yeah, one side was going to be more compromised. And then cord equina is when it goes below the spinal cord. Yeah, so the spinal cord will cut around T11, T12, L1, depending on the morphology of the person, will change, and then that's where the nerves come out. So instead of having an upper motor neuron injury, you might end up with a lower motor neuron injury. Although nowadays they separate, but we can start drawing some conclusions from this examination and see how the patient is progressing. Okay, but of course, this is not the only thing that influences. Yeah, this it gives us an indication, but we also need to look at what's the age of the person? What were the habits before that? Yeah, what's the age? Do they have pain? Do they have support? Do they have other injuries involved? What's the medical history? Types of complications like pain, spasticity, overweight, all of this. How is the motivation? All of this will come into place. So sometimes you can have two people with exactly the same injury, and they will behave completely different. Yeah, so these are things that we're looking at when we are assessing and trying to get grips initially of this client.
So spinal cord injury, as you would all know, is a multifaceted condition and changes the person's life completely. So is the approach. Approach has to be multifaceted as well. And hence, it's a multidisciplinary approach. We like to call it multidisciplinary and interdisciplinary approach. But the key thing is we need different disciplines to come together and work together. And that's where the specialist centers specialize other than the general rehab centers, because they have these multidisciplinary teams working together. So along with the medical team, there is a specialist nursing team who understands spinal cord injury and its management, occupational therapy team, speech and language therapy team, psychology, music. We have music therapists and access to orthotists and podiatrists. Peer support is very, very important, along with psychology, a dietitian or nutritionist, solicitors and case managers. They form the team of the person. Family and carers are integral to the team. We say hospitality team because when patients spend such a long time here, the hospitality team also becomes part of their team, and looking after them and in their day-to-day, in their daily stay here. Not only just the teams, the nature of spinal cord injury requires different skill mixes. We need counseling, we need patient education, which is absolutely paramount in managing spinal cord injuries. It is to empower and educate patients, and not only patients, their family members, their carers, to understand their condition, be their own advocate when they leave us from the rehab center. Bowel and bladder specialist management, upper limb rehabilitation and restoration, hand therapy, orthotics, aquatic therapy, locomotor training, pain and spasticity management, respiratory management, assistive technology, seating and mobility. The list goes on. And this gives you an idea that these are the skills a specialist center must have for a holistic and a complete rehabilitation. And rehabilitation doesn't start or stop in the rehab center. It goes on. And as a specialist center, we ensure that the things that have been, or skills that have been given to the patients while they're with us, are carried out in the community as well. So the specialties and the disciplines, they all work on both 4 basic principles in the acute and subacute stages of spinal cord injuries. And the principles are prevention, preservation, patient's participation, and preparation for community. I will take each of them in details in the subsequent slides. So prevention. Spinal cord injuries results in the motor and the sensory loss of autonomic function or impaired autonomic function, respiratory issues, depending on, as Marcella said, the level of injury. So the first and foremost thing for the team is to prevent secondary complications arising from these injuries. Managing their respiratory health, because no matter what the injury level might be, patients are on bed rest for some time. They might have undergone a surgery. Their respiratory health would be compromised. So that needs to be addressed. Preventing soft tissue tightness, again, by the nature of or the level of injury, they are prone to joint integrity being compromised. The length of the muscles and the soft tissues can be compromised. So our foremost approach is to prevent these complications, prevent tightness, contractures, prevent infections like bladder infection, because they have bowel and bladder incontinence, so they're prone to infections. Maintaining skin integrity, just because again they're on bed rest or the mobility is reduced in the initial stages quite considerably, so they are and skin itself is compromised. The health of the skin. So there's a huge focus on preventing pressure sores or skin breakdowns. Management of edema in the limbs and management of pain and spasticity, which is a huge hindrance to rehabilitation throughout the rehab process. So the nurses, the therapists, the medical team, we all come together and we address these issues and give a plan. Building on that is preservation. So below the level of injury is the motor sensory loss, but above the level of injury is also affected some or the other way. So our goal is to preserve what is left from the injury. If it's a complete injury, then definitely yes. But we're seeing more and more incomplete injuries. As if you recall from our second or third slide, the statistics, the trend is now more towards incomplete injuries. That means there's so much more innovation below the level of injuries, and there's so much more work. And the over the course of time, our patients are still recovering. So we have to ensure that we maintain the, again, repeating myself, is joint integrity, providing mobilizations through various hands-on techniques or technologies. We have a program for them, maintaining the length of muscles through positioning, through stretches, strengthening programs, splinting if required, ensuring that the limbs are positioned in a proper way, 24-hour posture management, and then once in our initial stage, when patients come to us, they come to us when they're medically stable, and they're ready for rehab. And once we have them for 2 weeks, that gives us a good idea of what factors need to be prevented or addressed immediately, what factors how do we prioritize, because there's so much work to be done. How do we prioritize the preservation approach? And it's again a multidisciplinary approach. The dietitian will be working from their point of view, ensuring that patients get enough nutrition to maintain their health and participate in rehab. The occupational therapist would work from the function point of view. The physio will work on the physical side of things, maintaining the ranges and the muscle strength. And then we have other disciplines like music therapy, orthotist, who would start the process from early on. And then it's very, very important that the patients are mobilized early on and participate in their rehab program from the day one. I mean, they are the heart of rehab. They, as we always say, you are the boss, and we are your team. So when they come to us, they have team Mike or team Claire, and we stick with them for the rest of their stay. So as I mentioned, early participation, we all work together and ensure that patients start to make their own decisions, because a huge part of spinal cord injury is losing control of their lives, losing control of what the roles they were playing. So it's absolutely important to teach them to take that control back. And it's in our daily practice, it's absolutely surprising to see the patients were highly functional. They were the MDs or the CEOs, but the injury gives them that sense of loss of control, and that's what the rehab process aims to give, that control back through education, counseling, making them the bosses, and we are the advisors for them. So we encourage patients to participate in their own management, in their own care early on. We encourage them to participate in their day-to-day lives, ADL in the ward, or when they come in the rehab, we provide ADL training. Mobility, we give them suitable mobility devices, whether they are a walker or on a wheelchair, that has to be addressed straight on so they can get independent in mobility. So they're mobilizing around in the rehab unit on their own. We encourage them to be part of their transfer practice and actually take a decision of what would be the right way of transferring them, given the limitation of the injury. Personal care, feeding, and say adjustment issues, which is again, coming to terms with what has happened to them, and how to empower them with the ability they have. So focusing on their abilities, focusing on their potentials. So we work in an interdisciplinary capacity, taking turns. Sometimes we have joint sessions with the nurses, with the physios together, and that is the beauty of this place, that we can do so. We can work in an interdisciplinary fashion. So some of once we have had the patient and we have understood patient's condition, level of injury, their priorities, what was their background, what were the occupational roles they were playing, we then make an individualized rehabilitation program and focus on giving them the skills to go back to their community. So some of the things which I have mentioned earlier as well, the skill mix that we need and the training that we need to deliver to the patients, like the nursing nurses will teach them how to manage their bowel and bladder. First, understand the nature of their bladder, nature of their bowel, and then give them education, how to manage, give them training, how to train the bladder and bowel. And then ADL and ADL training starts early on. How would they transfer functional re-education, we like to call that, and giving them skills to mobilize, whether they're in hospital bed, whether they are in wheelchair, how would they mobilize, do pressure reliefs, how will they change position, how would they go from point A to B. Low-level injuries are completely different to high-level injuries. And that's why this is a general view, because if it's a patient is a cervical patient, our approach is slightly different to a patient who is a lower level injury, a thoracic approach, or an incomplete injury. But overall, this kind of covers this everything that we do with this spinal patient. Seating and mobility starts from day one. How are they going to sit in the bed? How are they going to move in the bed? What will be their first seating solution to get them from A to B, get them from the ward to the gym, get them from the gym to outside. Seating needs change as the patients are making the recovery or they are getting stronger in their rehab. And we continuously monitor that. The wheelchair setup is changed, the type of wheelchair they require changes. So this process starts from day one and goes on till they are in the community and further. Respiratory health is absolutely important, and that is addressed from early on and ongoing in the community as well. Psychology support and counseling is absolutely essential, because it's not only the physical impairment or the physical devastation they are facing, it's an emotional setback as well. And a lot of time patients might be physically ready, but they're not psychologically ready. And we understand that. And as a team, and it's not just a counselor or a psychology, it's the team provides that support, that team gives that encouragement to pick up where they left and engage in the rehabilitation process. Community reintegration, which we will pick up later as well. Communication and assistive devices, assistive technology for very high level injuries. We work with Aspire charity that gives us, comes to us and assesses patients. And then we have our own kit of assistive technologies as well. We have a speech and language therapist. That again depends on very high level injuries or patients who are on ventilators, to have a communication aid, specialist communication aid. And all that, yes, there are humans around the patient, but technology is completely at our heart, because without technology, we would not be able to give an intensive model that we do. So we are very fortunate to have an array of technologies, latest in the market, and Marcelo will elaborate on that.
Yes, as you said, it's quite so having an injury in itself is quite mind-blowing already. It's quite overwhelming. And then when it comes to the world of rehab, then that we have all this technology, we need to find ways to get all these people working together. This is the challenge, getting everyone to work together towards the same goal, towards the same objectives. And yes, there are a lot of different ways of reaching those. Yeah, there for us it is about finding what works for each person. We know that high dosage, intensity, experts approach is what's needed to, for that person to feel supported and to then support that person in moving on. And then finding the right technology as well is key to see how we can find, and it's about getting everyone together. So yes, we do have a lot of stuff and we're quite happy with that. But it takes some time to grasp the whole thing, and especially if you're coming from outside, if you're not used to see spinal cord injuries every day, especially as case managers as well, sometimes you get, because this physio recommended this OT recommended that. So we try to get this everything in a package and then try to match, with patients' expectations, and because we need motivation as well. It's about the intensity, the dosage, but it's also about the motivation. Is what keeps the person engaged as well. Yes, we got all these different bits, from sittings to virtual reality to electrical stimulation, exoskeletons, and etc. But there are two things that I think in terms of physical movement, there are two things that sort of really come out with patients who had spinal cord injuries. One is that they want to move their hands, they want to use their hands, and they want to walk. Yeah, in terms of physical aspect, that's the things that always highlight, and they are quite complex. Yeah, on the way we deal and the way we manage them. So when you talk about hands, again, there are a lot of different options, and the hand is quite complex. When you look at the representation of the hands in the brain, it takes a huge part of the brain because it's so complex. It's so, the sensory, the movement is so complex. Well, is the complexity that can, play a full sonata, a full symphony in a piano. It comes from this dexterity. Yeah, we can identify what's on your hands and etc. And this is so fundamental because that's the way we communicate with her. That's the way we have our relation with the world, is through our hands. So there are different devices that they go from, functional electrical stimulation, try to get these muscles firing up again, try to facilitate the firing up, or try to facilitate movement. We have options on the screen there with 3D printed devices. We have orthoses, we have pneumatic gloves, electrical stimulation, as I mentioned. There are robotic options as well, just to facilitate movement, to facilitate pattern, and to give repetition, to favor a more, just to facilitate movement in general. Yeah, that's what we want to get, is to allow the person to move and to experience movement. I think is all about this. Yeah, because the thing is, if you want to learn something, if you want to play the violin, you have to sit in front of the violin and you have to play the violin for 10, 20 years every day. Yeah, it's the same thing. If you want to relearn to use movement, you need to have something that will facilitate this dose, this representation on your brain and on your spine to bombard the spine and the brain with this. And that's where this sort of robotics, that's where technology facilitates, either by being a robotic arm or suspended arms, or just to get this motivation as well for virtual reality and games. Yeah. We'll also look at in different injuries, you're going to have different representations of how your body presents, as I mentioned before. Yeah. So when you talk about higher levels, cervical injury patients where they have the hands affected, sometimes we need to think about how do we retrain the hand. Sometimes we might not have, the function of the fingers back, for example, but we still can use other ways of adapting. And then we need to prepare the body. We need to train the body to adapt. For example, as an example here, we have the tenodesis grip, which is when you use, instead of using the grip from your fingers, you end up using the passive resistance of your hands, of your tendons, to use the wrist to provide grasp. And then there are different tools as well, but we got to make sure that this person is well supported, to make sure that the length of the muscles are there, that the tendons are there, that the joint is healthy, because then we can start training and provide this. That's when it goes into that prevention, promotion, preservation we were talking about. So this is on hands. We also talk about movement, about gait. Yeah. So gait is much more than just walking, than just taking steps. Yeah. It is about locomotion. Again, is body representation. And I think gait is very related. These two topics, but especially gait, is not so much about the taking steps, it's much about the sensation of freedom. Yeah. Because we always relate the walking with freedom of movement, with the fact that if something is bothering me now, I can stand up and I can walk away from this conversation. Yeah, we can do that. I can run away. I can go wherever I want. That's the representation that walking has. That's why it's so important. Yeah, because sometimes it's much more important. It's much easier to get on a wheelchair. It's much faster. It's quicker. But still, walking has got this relation with freedom. So there are different ways of doing. Again, you can use robotics, suspended systems. In the past, we had, for example, suspended systems. If you see on the left, we got two therapists there. Going one on each leg is quite time consuming. Nowadays, we have robotic devices that can do that and can make the whole thing more efficient. Because again, as with hands, is about dosage, is about allowing the person to be there, and there are different ways of standing, there are different ways of walking, and you need someone with an expertise to have a look and try to identify and try to make the right choices rather than wasting time. On that line, so you got this type of device that's like a robotic, hard shell exoskeleton that comes on a treadmill, but you have these wearable devices as well. It's quite in hype now, exoskeletons, and everyone wants an exoskeleton, and they are amazing. Don't get me wrong. We do the assessments for most of them here. We have 2 in-house, and the others we usually facilitate via colleagues. So we had this expertise because it is a big thing, especially in the sort of the case management type of world as well. And it's part of it. And then we would like to, I can talk more about this. I could talk the whole day about it, yeah. But there are different ways. And also, how do you support, is there a foot drop or etc.? Do we need to look at orthosis as well? That's what we're looking to deliver this. Yeah. But I'm gonna leave that because otherwise we're gonna talk the whole day for sure. Yeah. Yeah, that's it. Yeah.
So we talked, Marcel has just spoken about mobility through exoskeletons, and I mentioned that mobility obviously is addressed in various ways. It's through wheels, which is a wheelchair mobility, or walking, gait pattern, although gait training is not just for walking, it has its physiological benefits, and our patients would go through that, whatever the level of injury permitted by the type of exoskeleton, but just for the physiological benefits of walking, patients with complete injury also come to us for just walking 20 minutes, 30 minutes. And it is evident that there are changes to their bowel and bladder management, spasticity, pain, and just general feel of well-being. So apart from being functional, there are physiological benefits. And that does not mean those who are walking on EXO are walking just on EXO. They would be wheelchair users for the rest of the time, because after an injury, and depending on how much bill you have to pay after your level of injury, if it's spinal cord injury, it leaves on how much energy a person has. He might be a walker with different aids, but actually it's too tiring and it's too energy consuming. So they would be using wheelchair for their day-to-day function, but walk with the device for some function. So there's always this mix of mobility. So, and when I mentioned from the acute stage where mobility changes, it keeps evolving throughout the process of rehab. The chairs are quite stable in the beginning because patients need to be quite comfortable and stable in the chair. And then the chair, the model, the looks, they keep changing and evolving throughout the rehab process. There are stable chairs, and there are high level chairs, and their chairs is like a minefield. They're like choosing a pair of shoes. There is a wheelchair for every purpose, whether it's indoor functional use, outdoor, going on pavements, going rough terrain, even trekking, going on beaches. There is a chair for each function. But that's where you need a specialist to guide patients, because we do have patients who come and they have 4 or 5 different types of chairs, but actually they don't use any of them. So that's where you need an expert to guide them, what suits their lifestyle. And it's not just the lifestyle, it is managing the space, it's managing their resource so that a solution works for most of their problems. So seating is huge throughout. We would trial different types of wheelchairs solutions, a pressure cushion, backrest types, outdoor wheelchair solutions, indoor wheelchair solution, hybrid wheelchairs, power chairs, stand-up chairs. They're different. It's a specialty in its own. So we do that, and not only for the time they are with us, but thinking ahead. Some patients would be wanting to go back to work, and there would have to be a separate wheelchair solution, because they have to get the chair in the car, whatever car they choose, or sometimes they choose a car depending on what wheelchair they are on. So it all depends on where they are in terms of funding, where are they in terms of the lifestyle they're going to pick up after their injury. Are they going to go back to work, or are they going to be more outdoor person? What were they like? So we as a team, we assess, and then we guide them, and we give them, as we say, tools to keep in their toolbox. Some of the tools might not be useful while they are with us, but when they've left us, it might be, oh, I saw this chair. I mean, didn't think much of it, but actually could be useful, because now I can take my dog for a walk. So that is an off-terrain chair, but I didn't think much of it when I was in the rehab center. So we do think ahead, and we arrange trials to give them that education and informed, allow them to make those informed decisions later on. These are, building onto the chairs. It's not just managing their condition, managing their impairment, but promoting a healthy lifestyle, like we all do in a normal, non-injured person. So we start planting those seeds early on in teaching them how to eat healthy, and we have patient education and peer support. We have externals coming in who talk from their experience, their wheelchair use themselves, how to keep themselves fit and healthy. And it's not just the therapy program. When they leave us, they are individuals with injury. They're not patients. They have the same needs to be fit and healthy. We teach them, guide them to access the local accessible gyms, have a fitness program, and if suitable, access local swimming pool. With low-level injuries are very successfully using the local swimming pools for various benefits of aquatic therapy. Introduction of sports is absolutely essential while they are with us, because if it doesn't happen here, it's unlikely, or there's very little chance they will pick it up when they leave us. Shoulder preservation from early on, because shoulders are not meant to be pushing chair or using an assistive device or pushing for transfers. So the health of the shoulder, and how to manage and how to do the energy conservation, we teach them while they're with us. So teaching is a huge part of rehabilitation, and cannot be compromised, because ultimately patients are their own advocates. And I'm sure most of you who have dealt with spinal cord injury would know that when they're back in the community, they are their own, they know their condition better than anyone else. Even in the general hospitals or GP services they go to, they have to know their condition better than the others. And as I said, sports, so there are a couple of charities, Wheel Power and Backup, that offer sports, and we don't have facilities here, so our patients go to Stoke Mandeville Gutman Center, and we encourage them to be involved in some of the other sports. And this is all things that we spoke about, is preparing them to go back to their community and live the life as much as they could, with technology, with adaptations. And we are here to guide them, facilitate that preparation and step down to their environment. So the fitness program, as I spoke with, and then we make referrals, because it's important when they go in the community, they have their own network of support. So we make referrals to the community services, and we advise them on patients' needs. Training and education involving families is throughout their stay here. Patient families are involved in their care. We provide training to the carers, because care team might not always be a specialist spinal care team. So they go through a 2-day, we recommend at least 2 days here, and spending time with the therapist, with the nursing staff, to understand patients' specific needs. And then home, discharging home is a huge area, and we prepare early on. As most of you would be aware, with a spinal cord injury, you would need some major or minor adaptations, which have to start in the beginning while they're with us. So we guide them on home adaptations, and we facilitate day leaves. So they go home while they're with us and they during the day and come back, and then gradually build it up to weekend leaves and overnight stays when they're approaching their discharge, to build that confidence in the patient, but also within the family members, that they can look after them. And also trial the discharge arrangements setting. And a lot of time, this is an eye opener, because they go on a weekend leave and then they realize they can't do A, B, C, D. So we still have a lot of time in the rehab process to sort it out. So we absolutely recommend that they do weekend leaves and overnight stay. Community reintegration, and we don't have vocational therapy in-house, but we refer our patients. We would do access to work if that's what they wish to see the work. If they're going back to work, we facilitate that and help them. Transport and mobility, we would advise them on the car or the vehicle they're choosing, depending on how they're going to transfer. If they are taking up driving, we facilitate driving assessments here, and we send patients to the driving centers for the recommendations of adapted vehicles and controls. And building on to discharge planning, so we have, by this time, we have given our advice on environment modifications. We would be working with their whether some patients are proactive and they have the resources to start modifications early on, and some would look for an alternate accommodation, and we facilitate again in terms of advice on what adaptations they would need. We would do home visits, we would do access visits with them, and then arrange for suitable equipment to be in place, whether it is through the statutory services or private purchase, but we will ensure that they have the equipment in place before they are discharged, and then they've trialed and tested it on their weekend leaves or overnight stay. Care packages, well, we don't give care or arrange care packages. We would only do that through social services where appropriate, but we do provide carer trainings. And if there are assistive technologies involved or environment controls required, then we have the resources to advise them and put them in the right direction. And rehab is being in the center is only a small part of their journey. The main part is being in the community. So their ongoing support is absolutely paramount. So we get the charities like SIA, Aspire, and Backup involved early on. We have the volunteers coming to us regularly who then can follow these patients in the community, and patients would have made a rapport with them anyway. So they've built that trust, and that carries on in the community. So it's important that they have a close community network and support through statutory services and charities and volunteer through volunteer organizations. And summing it up, as Sir Ludwig Guttman, who was the founder of Spinal Cord Injuries, said that patients with spinal cord injury require support from their injury to the grave. So although the NHS spinal centers provide this lifelong follow-up, they're obliged to provide the lifelong follow-ups. We, as in here, we also provide that support in the term patients come back to us for follow-up, rehab top-ups, and contact us for advice and support. That's in a summary, a huge topic summarized in few slides.
Thank you so much. That was just fascinating. It was it's all things that a lot of people see. I'm sorry, I've got terrible feedback on here. A lot of the things that you've mentioned, most of us have seen with our clients, but it was so fascinating and brilliantly delivered. So thank you for that.
Thank you.
I'd like to kick off with a couple of questions if I can. generally the people that you see will be fairly new after injury. Am I right?
No, not necessarily. Sometimes, as Shiva mentioned before, it could be someone, as soon as they're medically stable, they can come to us. So yeah, so we would have that person who would be like 2, 3, 4 weeks onwards. But very, very frequently, we have people who are like 1, 2 years, or sometimes 10 years, 20 years post. Yeah. So what we see is that the intensive approach. So they will need, as as Dr. Gutman said, you need support to the grave. Yeah. And the way the injury impacts someone will change in the same way as everyone will get older and have new difficulties. Things, they do progress. Yeah. There are new technologies. There are different issues that can happen in someone's life. And all of so it could be that they will end up coming here for another period of of rehab to work on a specific thing. So for example, we had someone coming next week. He is 15 years post injury, but something happened to his shoulder, and then the transfers are now gone. So then he works to work on transfers, right? So this happens. So not only we just don't get the very extremely acute, because they go to a trauma center then. But as soon as they're medically stable, then yes, then.
And some patients keep coming to us for rehab top-up, as Marcella said, and sometimes their condition has changed, something else has happened, so then they come to us. We have people who come from abroad, and they come for very specific goals. So we do cater for that too. So it's a small, short burst of rehab for 2 weeks or 3 weeks, and with very specific goals.
Okay, that's really helpful. So if there was, so you start at the age of 18, I understand. Is that right? You don't work with children?
Well, no, we're not licensed to work with children.
Yeah.
Okay. So an 18-year-old spinal injured person with lots of other complex needs, who hasn't had this sort of intervention, injury was at 2 years old, but he is now 18.
Sorry, Jill, I think your voice is cracking so much.
I don't know what's going on with my, can you hear me? Can you hear me?
I can. I don't know if.
Oh.
The terrible.
Sorry,
yeah,
our connection is poor. I think we can hear now.
Okay, so a client who injured at age 2 has had no intervention like this.
I think
you've lost me. Okay, I'll hand it on to somebody else.
We can sort of hear you there.
If it helps.
You're asking about his 18-year-old, and then we sort of lost you there. Sorry.
Okay.
Yes, please. Yes, if you could type.
So I'm looking at if a 2-year-old injured who is now 18, would that be somebody that you could help?
Mm-hmm.
No. Okay. Hand it over to someone else.
Yes. Well, in fact, we have what?
We do.
So
what we do, Jill, is when we have most of the inquiries, and we would screen those inquiries on phone, one of the clinical member of staff will speak. And then if we need an MDT's opinion, then we offer an assessment. And then in the assessment, we would give an honest opinion. What can we practically achieve?
Okay, no, that's good.
I don't know.
Yeah, thank you. Anybody else got some questions? I'm hogging this, so can someone else jump in here?
Yeah.
I
can connect on the.
I had a quick question, sort of on the back of yours, Jill, which is I was wondering at what point do you guys see the most MDT involvement? Is that right at the start when the client comes to you, or is it or maybe at the end when they're just sort of getting ready to go back to work?
Sorry, could you repeat your question, because I think the quality of network is poor here, so I didn't get the question at all.
Yeah, no, that's okay. I was wondering at what point in the process you find the most MDT involvement from as much of the team as possible, or is it a client by client basis?
No, MDT is involved in, I would say, 99% of the cases. I mean, there's always some a contribution a discipline can make, but the more complex the cases, the more members are involved. In the sense, we have some external associates as well, so we have an access to them. We would not need them. Like let's say a podiatrist, not needed for every patient, but if we need, we get a podiatrist. So the team can get bigger depending on the complexity of the person.
Thank you.
Yeah, and then what can change is that we have different meetings as well. We try to meet as often as possible to try and discuss and make sure that everyone is on the same page. So this we do quite frequently. And then, of course, the more complex the case, the more meetings you would need as well.
And do you find that the frequency is increased sort of towards the start or at the end of your involvement or of the recovery?
So usually when starting, usually we have this initial 2 weeks when they come to us. This initial 2 weeks, after the initial 2 weeks, we sit down with the whole team, case managers, solicitors, family, whoever needs to be involved. We sit down to discuss the plans moving forward. And then, of course, this will depend as we start to get closer to a discharge date, then they start to become more and more frequent then. Yeah, but it will change from patient to patient.
So thank you.
Any more questions from anybody else? I have one more. Is there a typical average time that you would have an intake? You'd have somebody coming in for, would it be 2 weeks, 4 weeks, and then a break, or how would you have is that something you could tell us?
So when we encourage that if it's an inpatient admission, we do an initial assessment, which is an MDT assessment. And then in that assessment, we give an estimate that this person would need about 6 to 12 weeks. But not from just the level of injury or condition, but when we've assessed, then we give and some patients do not come for the MDT assessment, then we suggest a 2-week inpatient assessment only. If they are more complex, some people come just for spasticity management. We do not know unless they've trialed the therapeutic intervention. So then we suggest stay for 2 weeks, and then we'll let you know how long will it take you to get the goals.
Yeah, exactly. It really depends. Also depends this whole, coming and breaking and come again. We like to do that, but it really depends what's the condition of the patient, and then what are the whereabouts, what's the home situation, do they have support at home, and etc. If they do have, then yes, then we can facilitate that.
Okay, that's great. I have a question here from Augustine. What type of psychological or psychotherapeutic therapies are offered post-injury besides the physical aspects? For example, is something like art therapy offered?
Yes, we have a recreational therapist. In addition, we have music therapy, we have a counselor, and we have a clinical psychologist.
Excellent.
Yeah, and then we try to facilitate group sessions as well. Then more about the socializing. Then there's always a rehab aspect behind, but it's more about the socializing. But again, it changes from person to person. Yeah, you could have someone who has traumas and PTSD and etc. So it varies.
Just one more thing, really. How do people refer to the Royal Bucks?
Well, you can refer to just picking self-referral, comes through the consultant, comes through the case manager, but someone, even a patient, can call in and say, I'm looking for help, what can you do? Our clinical team would then speak to the person to understand what are their needs, and then we call them for an assessment. That's our kind of best. If it's an inpatient, even for outpatient, we would call them for an assessment.
Lovely. Okay, and somebody has already, Shelley's already left. She said she has to go, but thank you for a very interesting and informative session.
No, thank you.
And thank you so much. It really has been very interesting and informative, and I'm really grateful to you. Hopefully other people will send in their comments as well, and we'll pass them over to you. And if no one's got anything else to add, I'd like to say thank you again, and hopefully I'll be working with you in the future.
Yes, definitely, Jill. And just let us know if you want to come around. We will be very happy to organize that. Just drop an email.
Indeed, I will. Thank you so much.
Perfect.
Thank you for your time, and thank you, everybody.
Thank you, guys.
Bye.
Thanks, everyone. Thank you.
Thank you.